coming to our conference on minding mothers with morbidities. This is our second conference, and obviously the first one was face-to-face. This time we can't see you, but we're delighted to welcome you all here today. To begin with, I just want to introduce the MAMI and MAMI Sim research teams. I'm Cecily Begley. I'm Professor of Nursing and Midwifery in Trinity College Dublin, and I lead the MAMI Sim programme. I'd like to introduce Assistant Professor Deirdre Daly, who is the leader of the MAMI study.
Morning, everybody. You're very welcome.
Associate Professor Margaret Carroll, who led the Galway section of the study.
Morning, everybody.
Professor Agnes Higgins, who's the Professor of Mental Health Nursing here in Trinity College Dublin. Dr. Pat Moran, who's a health economist and leads the monetary aspects of the study.
Morning all.
Dr. Sunita Panda, who led the cesarean section strand and is assisting Pat on the monetary aspects.
Good morning, everyone.
Dr. Brenda Lynch, who has worked with Dr. Francesca Vitek on the second baby study.
Morning, everyone.
Dr. Deirdre O'Malley, who's the leader of the sexual health strand. And Kathleen Hannon, research administrator to the team, who has organised this whole conference.
Good morning.
We have a very packed programme today. We have 13 national and international speakers presenting all their research on maternal morbidity across the world. And then at the end of the day, we will have a session with Dr. Catherine Gill from the Health Research Board. The Health Research Board is one of our main funders for the whole MAMI and MAMI Sim programmes and have funded this conference as well. I'm just going to give you a brief overview to the MAMI programme of research, and then I'm going to hand over to Deirdre Daly to tell you a little bit more about it in detail. The MAMI study has been going on since 2014. These are all the strands. You can see there's a large number of them. At the moment, we have over 3,000 primiparous women in the study, and we have data collected during the antenatal period and in the postnatal periods as well, right up to 1 year. We expanded the study, starting initially in the Rotunda Hospital. We expanded down to Galway and then to the Coombe Hospital here in Dublin. The MAMI Sim programme was developed more recently, about 3 years ago, and this incorporated 3 studies employing 3 postdoctoral researchers to look at the second baby study, women having their second babies, the monetary aspects, the finances involved, and an intervention in urinary to try and address urinary incontinence. So, over the whole programme, we've had 5 PhD students and 2 MSc students have completed their studies. And throughout the whole programme, we have co-conducted the research with women. And I'm delighted to say some of the women who've taken part in the MAMI study are with us today and will also join with us this afternoon in a workshop to try and action results out of the study. So I'm going to hand over now to Assistant Professor Deirdre Daly, who's going to tell you a little bit more about the MAMI study in detail. Thanks, Deirdre.
Thank you very much, Cecily. What I want to tell you now is a little bit about the maternal health and maternal morbidity in Ireland study, the MAMI study. And this is to give you a bit of background of why we're doing what we're doing and how we are doing it. So back in 2011, we set up the MAMI study to look at women's first-time mothers' health before and during pregnancy and up to 3, 6, 9 and 12 months after they gave birth to their first baby. So today I'll tell you a little bit about what we learned from the women and what women said about being asked about their health and their health problems. So the study started back in 2011 and was very much inspired from practice by one woman's story. And this is a woman who came to an antenatal clinic and didn't talk for a while, but eventually disclosed that she had been doubly incontinent, leaking urine and leaking feces since the birth of her first baby 2 years earlier. She cried and cried and described every aspect of our life as being miserable. Miserable. So we went looking to see what data there were in Ireland on women's health postpartum. And whilst we gather an awful lot of really rich, important data on women's health during pregnancy and during labour and birth, we stopped collecting and reporting nationally information on women's health, so that the focus very much moves from the woman to the baby. So the MAMI study was set up to identify the existence, extent and severity of maternal morbidities in nulliparous women, first-time mothers, before and during pregnancy and up to 1 year postpartum. It involved women completing 5 surveys, and these 5 surveys are lengthy surveys. They're about 60 plus to 80 A4 pages. We also collected data from consenting women's maternity records, and we interviewed women who were experiencing a morbidity like sexual health problems, like urinary incontinence. And the whole idea of this was to identify factors that could be modified in intervention studies. As Cecily said, we're currently on the second baby follow-up study and on the 5-year follow-up study. And we're also co-conducting separate research with women. So this is the way it looked in 2011 when it started. You can see there was, a total of 7 strands in it. It developed over time and many more strands were incorporated. Over those years, we recruited 3,047 women from the 3 sites. And that was about 2 in 5 of the women who were offered the study decided to take part. But look what happens at 3 months. These are women who have had their first baby. They're exhausted, they're coming to terms with motherhood, and the retention was 84%. It was actually about 83 to 93% over the 3 sites. So it was marvelous, and it was a real sign of women's commitment to the study. Most of the women are Irish. Most of the women are aged between 30 and 40 years of age, over 2/3, and that's probably reflective of what's happening in Ireland. Over 2/3 of the women are educated to degree level or above, and 9 out of 10 of them are in employment. Just under 2/3 were normal BMI, in the normal range, before they became pregnant, and that's self-reported. So what did they learn? What did we learn from them? Before pregnancy, 1 in 3 women leaked urine, any amount of urine. That was 8%, that's 1 in 12 women leaked urine monthly or more frequently. That's before their first pregnancy. During pregnancy, the prevalence increased to almost 2 in 5. And what also happened there was the severity increased. Look at 3 months postpartum. Over 1 in 2 women leak urine. And almost 1 in 2 leak urine at 12 months postpartum. 1 in 20 women leaked feces. That would be liquid or solid stools before their first pregnancy. It declined during pregnancy. 3 months postpartum, it was 1 in 10 women. 1 in 20 women, again, at 12 months postpartum. Before pregnancy, almost 2/3 of women told us that they had some sexual health issue, lack of vaginal lubrication, painful penetration, intercourse, etc. 68% in pregnancy, over 3/4 at 3 months postpartum, and again, almost 2/3 at 12 months postpartum. Almost 2/3 of women had pelvic girdle pain and back pain. 3/4 had it during pregnancy. That rose to almost 9 in 10 women at 3 months postpartum and 8 out of 10 women at 12 months postpartum. 1 in 10 women told us that they had depression before pregnancy, during pregnancy. That went up to 1 in 8 at 3 months postpartum and at 12 months postpartum. Almost 1 in 12 women told us that they had anxiety before pregnancy. That increased during pregnancy and declined to 1 in 10 at 3 months postpartum, but stayed around 1 in 10 at 12 months. Women told us about other health issues they had. These are things like tiredness, colds, coughs, minor illnesses, headaches, etc. And also sore perineum and wound pain. And for many women, they were very common at 3 months postpartum, and they persisted, particularly the coughs, colds, the things you get when you're run down at 12 months postpartum. But maybe they get help, and maybe we're asking about them. So here's what women told us about contact with healthcare professionals. And the numbers in red are percentages, and they're the women who told us that GP did not ask me directly about all of these problems. So you can see that many women said that we're not asked directly about loss of urine, bowel motions, hemorrhoids, etc. They also told us that the midwife or the PHN, that's a public health nurse in Ireland, did not ask me directly about leaking urine, bowel motions, etc. We also found out from the women that 12%, that's almost 1 in 8 women saw their GP more than 3 times. And that's for their own health reasons, not for their baby's health. 1 in 8 attended an emergency room. That might be at a hospital or a general one. And 5%, that's 1 in 20 women, were readmitted to hospital within the first 3 months postpartum. So there's a national silence. Most women did not talk about these issues, even when they were during pregnant. Midwives, GPs, and PHNs did not ask women directly about these issues after the birth. So what's the consequence of this? Health problems that could be prevented and treated may worsen and may persist. And that leads me very nicely into Brenda's talk, which is going to be on the second baby study, looking at the health and well-being of women after they've had their second baby.
Thank you, Deirdre. So this is done in conjunction with my colleagues Francesca Wetak and Tony Fitzgerald and Paul Corcoran in University College Cork. So this presentation is going to consider some of the baseline socioeconomic and morbidity characteristics between the MAMI and SIM study. So one thing that's important to note is the potential for non-response bias between the two studies. As we can see from this diagram, the MAMI study had a large sample across each of the surveys. So we can see from here, and as Deirdre pointed out, there was a very good retention rate across the 5 different surveys. However, there was some loss to follow up. Not everyone from MAMI would have been eligible for inclusion in SIM, as they would not have had a second baby in the time frame of interest. So obviously they wouldn't have been captured in the SIM study. In the SIM study, between the 6 months and 12-month surveys, there was 254 participants. We believed that those who completed all waves of MAMI would possibly have been more likely to participate in SIM if they were eligible. Participation in all of the MAMI surveys increases the likelihood of reporting symptoms of morbidities of interest. So therefore, to remove any potential bias between the two groups, so those who just had 1 baby captured in MAMI and those who had 2 who had also been captured in SIM, we minimized this analysis to only include participants who completed all MAMI surveys in order to reduce that bias. So my analysis here was conducted across those participants who were surveyed in all postpartum surveys of the MAMI study. So the preliminary analysis looked at comparing those in the MAMI study only and those who were subsequently captured in the SIM study. So we looked at age, BMI category, relationship status, qualifications, and employment on entry to the MAMI study for all of those participants. We also looked at morbidities across full survey responses in MAMI to assess differences in prevalence across the two groups before and during and after first baby. And then finally, across just SIM participants, we looked at morbidity reported at first and second baby. So firstly, looking at socioeconomic characteristics at entry to the MAMI study. So looking at maternal age at birth of first baby, those who only had one baby captured by the study, we can see that there is no substantial difference between those who then subsequently go on to have a second baby, both around 32 years of age. We also found no significant difference in the BMI category that was self-reported for those on entry at the MAMI study. So over 60% of both groups were registered as having normal BMI category weight with their first baby. So here we can see relationship status. So for both groups, over 90% of participants were in a cohabiting relationship, and no significant difference was seen between both groups in this category. Next, for qualifications, we can see that the majority of qualifications are either Leaving Cert Vocational or Primary Degree PG Cert. So we did find a significant difference here. When we look at those who subsequently have a second baby in the SIM study, we could see that more are registered as having a primary degree or PG cert at the time of their first baby, whereas those who just appear in MAMI had a higher rate of Leaving Cert compared to the vocational, Leaving Cert Vocational compared to the SIM participants. For employment status, there was also a significant difference between the two groups. We can see full-time was over 80% for those in MAMI only, and just over 90% for those in SIM. So when we looked at morbidities across the two groups, so those who just captured in MAMI with their first baby and those who subsequently appear in SIM, we can see that there was very similar reported occurrences of morbidities of interest across the two groups. There's no significant difference in reporting between them. So we looked at urinary incontinence, fecal incontinence, pelvic girdle pain, sexual health issues, depression, and anxiety. So there's very similar reporting regardless of which group these participants ended up being in. So as a result, then what we can see is there's no difference in the number of morbidities that were captured between the two. We can see that just over 90% reported having experienced 2 or more morbidities with their first baby. And this is primarily driven by the high incidence of reporting for pelvic girdle pain and sexual health issues that were seen in reporting of individual conditions. So then in terms of 3 or more morbidities, just under 60% for those who were only captured in MAMI, and just over 60% for those who are also in the SIM study. So finally, we looked at, does the reported occurrence of morbidities after baby 1 also occur after baby 2? So for urinary incontinence, those who were in the MAMI study who subsequently had a second baby, during their first pregnancy, they reported 54.7% reported having conditions of urinary incontinence. Of those participants who had positive reporting, when they appeared then in the SIM study, 50% of those reported a reoccurrence of urinary incontinence. So you can see here the percentages and then the numbers that reflects within both studies. For fecal incontinence, because the numbers were low, we can see here that only 2.7% who were in MAMI and SIM reported it during their first pregnancy, which only reflected six people. Those 6 participants did not report the same threshold of experiencing this morbidity on their second baby. For pelvic girdle pain, it was 98.5% reported it during their first baby. And of that, there was a very high reoccurrence, 92.3% reported the same morbidity during their second baby. So that was 180 participants. For sexual health issues, it was 97.4% having experienced issues with their first baby, and of that 84.8% reported a reoccurrence on their second baby. For depression, it was 31.5%, reflecting 70 participants, and then of that, those 70 who reported full survey responses for depression, 42.8% reported a reoccurrence. And finally, for anxiety, it was 28.5%, which reflected 65 participants in MAMI. And of those participants, 40% reported a reoccurrence of this morbidity in their second baby. So a summary of our findings. For socioeconomic characteristics of the study sample at entry to the MAMI study, their first baby, we saw a significant difference between participants in MAMI only and those who are also in SIM, seen in education and employment status only. No difference seen across the other conditions or categories. Does reported occurrence of morbidity differ among those in MAMI only, reflecting that they only had captured on their first baby, versus those who were also in SIM, where we captured data on their second baby? And we found that there was no significant difference between groups for reported occurrence of individual morbidities during their first pregnancy. And there was also no significant difference between groups in reported occurrence of multi-morbidities, reflecting that there is no significant difference between their experiences on their first baby. And then, does the occurrence of morbidities differ between first baby and second baby? We did see a very high reoccurrence of reported morbidities in SIM among those who reported those same morbidities in MAMI. So that ranged, excluding fecal incontinence, which had a very low occurrence in the first survey to begin with. It ranged from anxiety with a 40% reoccurrence to pelvic girdle pain, which was as high as 93%. So there is a reoccurrence of morbidities across the two pregnancies reported in both studies. So that's my presentation. So I'll be handing it back to you, Deirdre.
Thank you very much, Brenda. I meant to say at the beginning that for the participants, that we will be taking questions and answers at the very end of this session. So when we're finished presenting the MAMI study and the MAMI study findings and where we are now, we will open it up to all of you for questions. So what I want to talk about now is my involvement with the MAMI SIM study and particularly the intervention development part of it. As I said at the end of one of the MAMI study slides, that the whole idea of collecting all of these data was to see if we could identify any factors that were modifiable and could be trialed in later studies. So the intervention development consisted of a systematic review, one-to-one interviews with women on a particular issue, and designing the test and testing the feasibility of the intervention. And this intervention, because my study had been on urinary incontinence particularly, the intervention was going to be on something that might help reduce the prevalence of it as women went along through their pregnancy and postpartum experience. And one of the issues that we really wanted to look at and discuss with women was being reminded to perform pelvic floor muscle exercises. The first part of it was a systematic review that was going to look at the effectiveness of reminders to promote pelvic floor muscle training for preventing or reducing urinary incontinence antenatally and postpartum. So when I did the review, there was quite a lot of searched, over 6,000 citations. But when we went down to the final included studies, there was actually one that looked at an app reminder. And what really came out of the review was there were very different studies. They were done very differently. There was going to be a narrative synthesis of them, but there was nothing that you could pull together. And really at the end, at the bottom line was that there was very little research done on actually reminding women to perform pelvic floor muscle training. Conducted one-to-one interviews with pregnant or postpartum women using an interview guide. And following ethical approval, I interviewed 16 women. All 16 were interviewed over the telephone. That's what they chose. There was 3 pregnant women and 13 postpartum women. And one of the things we were talking about was, would you offer a text, an app, phone call, whatever. So 15 of the 16 of women use smartphones regularly. All would welcome a reminder. All would welcome a reminder via an app, but certainly not telephone calls or emails. They didn't want any of that. The reminder should include how and how often to do pelvic floor muscle exercises or training. And those should be embedded in the reminder. Almost all of the women wanted to be informed about the consequences of not doing pelvic floor muscle exercises. And they wanted factual and motivational information. And some of it used on a, if you like, a rotation basis. So here's a snapshot of what women said. I haven't got that much information on them. That's pelvic floor muscle exercises. And that was recurrent from all of the women. They wanted factual information, the positive impact of doing them, and also almost all of them talked about the consequences of not doing them, that would be a motivator. I use pads, it's the leaking that makes me want to do them. The consequence of not doing them would be motivated. That came up again and again. And 2 of the women in the study particularly made mention of the cost and the fact that some apps cost money, and when you don't know what you like, you're not going to buy it. And if you have no top up on your phone, you'll put it on the long finger. So it was a deterrent for some women. I asked the women what they feel what was enough in terms of reminder and what versus too much. And there was a sense that every day is probably too much. Maybe something that would give them goals for the week. It should be short, it should be visual, it should be clear, and it should include the consequences of not doing them. And ideally, they said that the frequency of the reminders would reduce as the habit has been developed and the women themselves see improvements. So that led there to the design of a feasibility study, and this is the one that we ended up with. And it was reminding women to perform pelvic floor muscle training during and after pregnancy, a feasibility study and a pilot randomized trial of evidence-based intervention. So what happened? Well, the first thing was that shortly after I set up the intervention, the usual care changed. And that's because the site hospital had developed and started using an electronic data system, electronic record system. And that meant that every woman was now asked at her first booking visit if she leaked urine. And if she leaked urine, the system automatically triggered a referral to physiotherapist or some action. That was a difference because when it wasn't electronic, that wasn't necessarily happening. The second thing that happened was general data protection regulations. And these resulted in 2 things. One, a delay in forms being developed to get ethical approval. And so that actually led to several months delay. Started recruiting in December of 2019. And this is where I think this is a wonderful example of live research and what can and can't happen. But recruitment was December in 2019, and it didn't go well at all, probably because it was on the eve of Christmas and the eve of New Year. So we started again, I started again in late January, February 2020. And that's when COVID-19 happened. And when COVID-19 happened, our university closed on the 12th of March 2020. Women had started taking part. I mean, there was over 6 women had already been recruited and were very interested in taking part of the study. But because the university was closed, it was not possible to collect the forms, so we didn't do the intervention. And I'm happy to take questions about it afterwards, but I would now like to hand you over to Sunita and Pat and Sunita, who are going to talk about the measurement of cost aspect of the study. Thanks, Pat.
Thanks, Deirdre, and good morning, everybody. Okay, brilliant. You're welcome, everybody. What I'm going to talk about now for a bit is the health economic strand of the MAMI SIM study. And this was a really new departure for the MAMI study over the last 3 years. And myself and Sunita have worked on it now, and we're going to present some of the interim findings. But first, I'm going to give just a short kind of contextual piece of what the aims were and what we hope to achieve from it. So really, the health economic strand of the MAMI SIM study was about trying to develop a better understanding of cost behaviours in maternity care and maternal health, and to look at resource utilisation patterns and how the flow of resources sort of works in this area, and then to use that information to perform a cost of illness study to quantify the overall economic burden associated with these problems and help kind of put this on the health policy agenda more, and to do things like identify the cost drivers and where the funding gaps might exist, but also crucially to provide the evidence base around, you know, what is the return on investment and the benefits of improving how this care is delivered, and what can be the kind of the longer term payoffs in terms of the economics of it, and really to generate that evidence base to support evidence-based policy making in this area. A quick overview of some of the ways we went about doing this was provided here. The first thing we did was perform a systematic review of the literature to look at, you know, what was the state of the art in this field, and what we found was that, you know, there hadn't been an awful lot of this type of work done in this area before, which obviously presents lots of opportunities for us to fill in some of those gaps. We added economic sections to both the MAMI SIM and the 5-year follow-up study, so that you know, there was a section in that big survey that Deirdre's already described that asked questions about resource use and costs that women experienced in terms of their care, and we supplemented that with interviews with 20 women. And this was an extremely valuable part of the whole thing, because it allowed us to get into, you know, a bit more depth in a lot of these issues, and get women's feedback on you know, how access to resources and utilization of resources affected them over the course of the period we were examining. And then when we had that data, we applied a lot of econometric and statistical analysis techniques to examine things like, you know, women's preferences for the type of care they receive, the healthcare utilization and non-utilization that occurred, and the costs of all that. And Sunita is going to talk through one of the results we have around a piece of research on utilization, and then I'll come back in again with some interim results from our modelling of this population and the costs and utilization. So I might hand over to Sunita now for the next bit.
Thanks, Pat. Good morning, everyone. I'm Sunita Panda. I've worked with Dr. Patrick Moran to look into the health economic strand of MAMI study and MAMI SIM study. I'm going to briefly talk about a specific part on utilization of general practitioner or GP service by postpartum women in Ireland. And this is what I'm going to talk to you today about, the prevalence of morbidities following birth of first and second baby utilization of GP service by postpartum women in Ireland, and relationship between the two, the postpartum morbidities and utilization of GP service following birth of first and second baby. So the aim was to analyze the difference in utilization of GP service by postpartum women who experienced urinary incontinence, fecal incontinence, depression, or anxiety. So the urinary incontinence and fecal incontinence experiences, where we looked into women who experienced leaking urine or feces more than once a month, or more frequently, like several times a week or every day. And any woman who experienced depression or anxiety, using that as score. So this is an overview of the prevalence of morbidities, of these 4 morbidities following birth of first and second baby, which you have seen in the last 2 presentations by Deirdre and Brenda. But I want to draw your attention to the experience of these 4 morbidities, ever after birth of first baby up to 1 year postpartum, and ever after birth of the second baby up to the 12 months postpartum. And what we see here is urinary incontinence was experienced by nearly 1 in 2 to 3 women in the first year after birth of first baby, and nearly 1 in 3 women after the second birth. Depression and anxiety were experienced by nearly 1 in 5 women up to 1 year postpartum following their first birth, and 1 in 3 women following birth of the second baby up to 1 year postpartum. So when we talk about the utilization of GP service, just to give you a background to this, in Ireland, women are provided with 1 free GP service at 6 weeks after the birth of the baby. But the findings from this study suggest that the women who in this study, they visited a GP more than 3 times for their own health up to 1 year postpartum in the first year after birth of their first baby, and for baby's health up to 5 times, and over 3 times before and after the birth of the second baby. Now, some of the visits could be related to, some of the baby health related visits could be possibly related to vaccination related visits. So these are not additive, and there might be some overlap. However, what it shows is that what's provided to women in Ireland, it is probably underprovided to what women actually have required. Let's look into more into the GP visits in the postpartum period for women's own health and baby's health. And what this graph suggests that there were few women who actually, in the cohort, who actually visited a GP more frequently for over 10, 15, 20 times for their own health and baby's health. Looking to the relationship between morbidities and utilization of GP service in the postpartum period, women who experienced urinary incontinence, fecal incontinence, depression, and anxiety were significantly more likely to visit a GP more frequently compared to women who had no morbidities. So what that indicates, what that suggests, that first of all, the prevalence of morbidities are higher for women in the first 3 months after birth of their first baby, and they continue to experience them up to 1 year postpartum after the birth of first and second baby. Women who experience all the 4 morbidities that we have looked into, urinary incontinence, fecal incontinence, depression, and anxiety, those women, they are significantly more likely to see a GP, to visit a GP, compared to women who had no morbidities. So the question here is, the service that's provided to women, is it underprovided? Is it tailored to meet women's needs? So it is essential at this point to emphasize tailoring care to what each woman experiences following childbirth than keeping one size for all. And I would like to hand it over back to Pat to talk more about the implications of cost of illness analysis. Thank you, Pat.
Thanks very much, Sunita. Okay, so you know, that I think that's a really good example of sort of the the utilization patterns and how they can change depending on parity and also on the presence or absence of each of these morbidities. And you saw there from the results that things like the GP utilization for women who experience depression and anxieties can be particularly high. And what I want to do now is follow this on with I look at some of the modelling work that we've done around trying to model the cohort of women who have a baby every year and track their health postpartum, using the data from the MAMI and the MAMI Sim studies, so that we can track, all the clinical events and the costs and the resources that are used typically up to 12 months. And if I could move the slides. Yeah, perfect. Okay, so what we did was we used this data to implement a Markov model which cycles through all the time periods that we have data for and tracks, what happens in this cohort over that time period. And we had to do this and to get to kind of national level costs and everything else, you need to we applied sampling weights to estimate the population parameters, because there were some slight differences between the study sample and the overall population. But the richness of the MAMI and MAMI Sim data is really, it's a massive asset. And the fact that it allows for disease-specific resource utilization to be estimated. And there's a picture of a part of the model. And what I'd like to do now is talk through an illustrated example of the type of information we can get from this work and how it can be used to inform decisions about how to make improvements to the care that people actually receive. So following on from Sunita's example there about GP utilization and focusing on UI, you could hypothetically say that we should try to get GP and physiotherapy coverage up to 100% within the first 3 months of postpartum, because we know from the MAMI data that women's utilization of these services is pretty low. So for women who do report experiencing UI symptoms in the first 3 months, 27% said that they spoke to a GP about it, and 28% said that they spoke to a physiotherapist about it. So it might be a good idea to try and ramp up those utilization rates to improve outcomes. And if we were to do this, one of the things that our work can do is estimate what the overall cost of this would be. And you can see there from the model results, we estimate that it would cost like just under €1 million to provide all women who experience UI symptoms in the first 3 months with a GP GP visits, and the average is about 1.34 visits per person, and it would cost about $1.25 million per year to increase the utilization of physiotherapy to 100% of all women who experience these problems. So that kind of gives you an estimate of the costs that you're looking for, which obviously is required information if you're trying to implement this. But also, our model allows for an example for an analysis of the uncertainty around this, because what can often, these figures can often belie the level of risk and uncertainty that pertains to a lot of these policy decisions. And there are a lot of tools that health economists can use to characterize that level of uncertainty and see, best case and worst case scenario and what it might actually mean in practice. And what this graph shows you is sort of the most basic one of those, which is looking at the spread of those costs. So even though we have a central estimate, there's a chance that it could cost more than 2 million per year to increase physiotherapy utilization to 100%. And then kind of the last and maybe the most important part of this is trying to relate these costs back to outcomes. And there's lots of more complicated ways of doing this than I'm presenting here, but for the purposes of keeping it simple for this presentation, what we did was we calculated what sort of improvement in outcomes will be needed for the additional costs of providing this over the first 3 months to be offset by the reduction in costs over the remainder of the first year. And what we found was that if this physiotherapy intervention could reduce the incidence of UI or the prevalence of UI by about 1/3, then you would have regained all the initial investment in improving these services by the end of 12 months, due to a decrease in the costs of consultations with consultants and public health nurses and GPs and physiotherapists over the remainder of that year. So although this is an example using real data, a full analysis of this would require a lot more nuanced treatment of these type of things. But it does, I think, provide really valuable policy relevant information on the type of things that you need to know to implement these interventions and take these policy decisions. So I'll finish up then with a look at what we're doing now is trying to model all of these areas together so that we get a better picture of the overall economic burden here and what impact it's having in terms of the health service budgets overall. There's also huge opportunities to model this, beyond the time period that we have in this study, and look at even things like the longer term impact of these in later life, beyond the kind of reproductive years, and even look at intergenerational effects of things like the impact of mental health problems on children's outcomes. And we also ask questions in the MAMI study around the impact of maternal health problems on things like their productivity in work and their future career prospects, which is something we want to go into a lot more detail too. And I'll finish then by just saying that we're talking about utilization here, but there's also the problem of utilizing the resources that allow us to examine these things in greater detail. And what we're really hopeful is that all of this hard-won resource will be used to help improve evidence-based policy making and provide the base that's needed to enact real changes on the ground that will ultimately benefit the people we're doing this for. So I'll hand over to Deirdre again, is it?
Thank you very much, Pat, for that. And it's fantastic to have that whole monetary side in, because it's so important, and particularly if you can show what Pat is talking about, that initial investment will have cost reductions, but huge health benefits at a later time point. What I want to do now, so we've started off telling you about the MAMI study and what women told us up to 12 months postpartum. That was on a cohort of women there who had their second baby. But I want to go back to tell you a little bit more about the MAMI study and where we are now in the overall MAMI study research program. So this is just a little flavor of what else we did and where we are now. When we set up the study, it was very much set up as a study research, not just about women, but very much with women. And the women had commented on, reviewed every aspect of the study, including the cover letters, the participant information leaflet, and particularly the surveys. Because the surveys were so long, there was a lot of questions being asked of us, would women complete them? The surveys were asking women an awful lot of intimate, private questions about leaking urine, feces, sex. Would they complete them? And what very much women said at the very beginning when they were commenting on the surveys is, yes, please do this, we need it. So very much they said is, bring it on, we need to do this. So it was set up as a study with women, not just about women. And that really, initially it was consulting the women, but along the way we shared the findings with the women and held seminars in Dublin and Galway on Saturday mornings with women. And we very much presented the information that they had told us back to them as their information, their stories. And what women said again and again was, you have to do something. You can't just tell us that that's the way women are feeling and that's what their health and health problems are like and they're persisting. You have to do something. So one of the first things we did was ask women to help us, if they were willing, to co-design the second baby study and the 5-year follow-up study. So this was 2017, before we started any follow-up study. And we asked them, would they be willing to be involved? And if we got more funding, would they be interested in being involved in an ongoing basis? Well, I'm delighted to say we got more funding from the Health Service Executive, and women did come, and they have co-designed our second baby studies with us and the 5-year follow-up studies. So they're all co-designed with women. Again, with funding from the Health Service Executive, we set up a public participation and research initiative. And I think we were overwhelmed by the amount of women who were really saying, yes, I'd love to be involved. I don't know how much I can give, but I want to be involved. So we set up the study. This was in 2018, and we held quarterly meetings with women. And what was coming out again and again from these women and from all of the women in the study was that they struggled to find reliable information. They struggled to find trustworthy information. There was plenty of information out there, but what could you trust? And because they couldn't find it, they felt alone and they were suffering in silence. And again, what they said at that very first meeting is, why are we here? This has to make a real difference and have impact. So we continued along and we got more funding from different resources from, these were all separate funding applications. And I'm delighted to say these were the ones that were successful, and they were all targeting at developing a suite of resources for women. So something that they would be able to go to. And these resources were going to be co-designed with women. And they were going to be based on the MAMI study findings, those ones that I showed you earlier. And it became translating maternal health research into maternal health resources. And what the women kept saying to us was, I wish I had known. And I wish I'd known what is normal and not normal, how I can help myself. And how do I know when I should seek professional help? So the resources were built around, as I said, the content of the MAMI study, physical health, incontinence, mental health, sexual health, etc. And importantly, they had women's voices throughout, and women's voices as the tip of the week. We had a core group of contributors, and a huge thank you to them. And their contributions and the whole resource suite of resources was being developed around the key message based on the message from the World Health Organization. It's thrive, not survive. Not just survive, women should be thriving in motherhood. So this suite of resources is called Women's Health After Motherhood, or WHAM for short, and the links are later on for you. Consists of lots of downloadable leaflets. They're interactive. And this particular one, the one in the first week, if you click on one of these issues, they'll tell you what the challenge is. They'll tell women and whoever healthcare professionals what the challenge, what's the definition, the key message, how you can do what you can do to help yourself. How do you know that point when professional help is needed? And the other thing, and importantly for a lot of women, how do you ask for this help? What words do you use? So there's lots of downloadable leaflets throughout. There's also fantastic videos by Cindy Cusick, who's physiotherapist in the Rotunda, and her colleague Neve Kenny, another physiotherapist, on knowing the science behind urinary incontinence. Why does it happen and when does it happen? And Cindy has developed these fabulous short coached exercises on how to do pelvic floor muscle exercise, and women love these. But the whole suite of resources is packaged as a 4-week program. It takes about 4 hours of that, and it's packaged, it's centered on women's voices, what I wish I'd known, their tip of the week for other women. And there's videos and articles from experts on anxiety, depression, sexual health, domestic violence, and advocating for yourself. We also developed other resources, and this was very much led by Cecily and funded by the Health Research Board. And these other resources were called On Track. And that's the link to them on the website there. And it was towards recovery after childbirth through knowledge. So these three are available in English, Romanian and Lithuanian. And they're videos on perinatal anxiety. And these ones include a gorgeous how to create a perinatal mental health wellness plan. Deirdre's three videos are on sexual health postpartum and how do you initiate that chat about having sex after, first time after giving birth with your partner. And Francesca and Cindy have developed lovely videos on pelvic girdle pain and positions on the movement and actions you can do to help yourself. Although it's not related to MAMI study per se, Cecily also got more funding to develop another suite of resources, which looks at women's health as they journey through pregnancy to birth. And this is another 6-week program, and it's all about how to empower yourself with knowledge, how to plan your birth, manage early labor, coping with main stage labor, etc. All of these resources are free. The links to all of them are here, and they're also at the end of the slides with the reference list. But the one point that I do want to emphasize is that we couldn't, none of this and the resources could have been or would have been developed and developed in the way they were without these women and their commitment. They've also committed to us in that over the years they have co-presented at conferences with us, and they're now co-writing articles with us. Their message was, you have to do something, you have to get it out there. And all of these women have contributed newspaper articles, media presentations. And this, it's the women's voices, as we know in many countries, that's going to help shape us as researchers and help shape services that should be out there for women. So where are we now? We're on the Public Participation in Research Initiative. We're just finishing on the second baby follow-up study. We're hoping to do international presentations and share and combine findings. And lots more to be done. A huge thank you to all of the women who took part and continue to take part. None of this would be possible without them, their commitment, and their willingness to be so honest and frank in sharing their stories with us. All of the midwives and the midwifery students in the 3 sites and the administration, other staff who really helped support the study as it is getting set up. And a huge thanks to our funders, particularly the Health Research Board would be one of our biggest funders over the years and would have given us several million euro over the time of the study. I want to say a huge thank you to all of the MAMI study team. I mean, this is a team effort, and sometimes it's a team effort when you have to lean on your other team members. So it's a huge thank you to all of those. And what I've done here is put in the publications, just a list of them at the end so that you'll have easy reference to them. At the very end, there is a list of the links to the Women's Health After Motherhood free resources in English, Spanish, and Dutch. And thank you. And I'm now going to hand back over to Cecily, who's going to chair the questions and answers.
Thank you very much, Deirdre, and all the other speakers as well. I just want to acknowledge the people, outside people who were involved in the MAMI Sim study, whom we haven't mentioned as yet. And they were the sponsors and mentors who helped and supported the 3 postdocs with their work. So they are Tony Fitzgerald and Paul Corcoran, looking after statistics and epidemiology with Brenda Lynch down in University College Cork. Michael Turner from UCD and the Coombe Hospital, and Declan Devan from Galway, who were looking after the obstetric maternity care side of things. And Charles Normand, Professor of Health Economics in Trinity, who was assisting with the health economics side of it. So over to Deirdre O'Malley now.
Yeah, thank you, Cecily. Thank
Yeah.
you. Brenda, I think we have a couple of questions there in the Q&A. Do you want to take some of those?
Yeah, so that Mandy also asked that question in the Q&A, but we've got, I wanted to know, did women in the studies have vaginal births?
Shall I take that, Cecily?
Yes, please.
About 1/3 of women in the study had a spontaneous vaginal birth, 1/3 had assisted vaginal birth, and the rest 1/3 had cesarean sections. So yes, women in the study had vaginal births.
Can I add to that, Cecily, if I may, for the questioner? And thanks, Anita. Yeah, most of the women in the study, when you see it, our intervention rate would have been roughly 1/3, 1/3. There was a bit of variation, but they're not that different from birth mode and outcomes for first-time mothers in Ireland, particularly when you begin to look at the regional variation.
And there's another question, was correlation with duration of labour and postpartum complication. So did you find any mothers who had longer duration or prolonged labour having increased risk to develop notified morbidities?
Anybody taking that one?
It's not addressed to anyone in particular, so I
Yeah.
guess it's...
Deirdre,
Well, I think you to answer it briefly is we have looked at duration of labour, first stage and second stage. And Pat might want to come in here as well because he's on the paper. And we've just published a paper a few months ago on that looks at that, but it looks at it in the context of use of epidural versus no use of epidural analgesia. So it's not necessarily duration of labour on its own, but it was in the context of epidural use in first-time mothers. So that's published in Women and Birth, August, September time.
I have a question from Paul. This is for your presentation, Sunita. Just the prevalence of UI, FI, depression and anxiety 1 year following birth of first and second baby. So I think that was on your slide where you...
I could just answer, sorry, Sunita, just for 1 minute, because I imagine a lot of other people will also have missed details. All these presentations will go up on our website later today or tomorrow, so they can get all the details there, you know, written down.
Perfect. And I think there's just 2 more if we have time for them. So Catherine said, since GP visits in Ireland can cost some €60 each, do you think this lack of free care has been detrimental for Irish mothers as well? Sorry, she just gave context there about the US showing higher morbidity and mortality based on the cost of visits, and wants to know if the same could be considered in an Irish context.
Yeah, I can take that one. Yeah, I think it's a really interesting question, and there is evidence to show that the number of GP visits that people need for, you know, if they experience these morbidities is far higher than what's provided through the maternity and infant care scheme. So that's an important finding. But beyond that, then, and to kind of consider the potential health outcome losses or utility losses associated with the under provision of this, and how much of a barrier the fees for accessing GP services are. It's a difficult thing to quantify, you know, to try and get an effect of all that. But you know what we are seeing is that people need and require more than what's provided here. So either they don't access it because there's a barrier and they suffer the health outcomes due to that, or else they do and they suffer the cost impact of having to pay for it out of pocket. And it's something I think that we want to look at in more detail as we proceed with this. So what we're kind of focusing on at the moment is the overall economic burden of this from a societal perspective. where we add in, you know, everything that everybody pays, whether it comes out of pocket or whether it's provided for by the public health service. But digging down into the detail of, you know, where these costs fall and what the impact of that is on how care is provided and what ultimately the health outcomes are is certainly something we want to look at in the future.
Right. Another question, do you know how many women had preterm labours?
I can take that.
Yeah.
So I analyzed, as part of my PhD, I analyzed the data for the whole cohort of women recruited to the study from all the 3 sites, and about 6% of these first-time mothers had preterm births. And we defined preterm birth for women who had a birth less than 37 completed weeks. We have further categories for women who had birth up to 26 weeks, up to 28 weeks, 30 weeks, but overall, anybody who had less than 37 weeks, about was 6% of those women.
Perfect. I have 3 more questions here. Deirdre, Wally, was there anything else on the raised hand function?
Thanks, Brenda. I don't see any raised hands. I think people are preferring to type in their questions.
Perfect. Okay, so we have 5 more minutes. Well, I think we have 3 questions. Are
Go
people happy to
ahead.
take those?
I'll stop you when we get there.
Perfect. So Paul, were there interrelationships between depression, anxiety, UI, and FI quantified? So I think that might refer to your analysis, Sunita, because they were your 4.
I haven't looked into that specifically for this presentation. What I was mainly targeting was to report on utilization of GP service for any woman who had experienced those morbidities. But we do have, and if you please do contact us, any of us in the team, and we can definitely give you those figures.
Perfect. And so for the feasibility study on pelvic floor health, you mentioned an app. How will that be different to all the other apps already available, or are you using an existing app plus other supports?
No, and I'll address that. Thank you very much. The feasibility study is not going to be tested anymore because of COVID and because of what happened and because my role in SIM has changed now. But the plan was to use a pre-existing app and to offer it free to women. That was the plan. It wasn't that we were going to design another one. We were going to use an app that has already developed, already used, but has never been tested actually or trialed.
Perfect. And there's just one last one, so I think we'll get this just in under the wire.
Okay.
Did women with UI or FI report difficulty in accessing public physiotherapy services post-birth? And that's from A. Connor.
Yeah, I can take that one. I think there was 2 kind of main aspects of the data collection about women's utilization of care, and one of the questions we asked in the survey was were there services that you would have liked to have received that you didn't because cost was a barrier, and the results of that didn't show, I suppose, as strongly as I might have expected that the cost was necessarily that much of a barrier. But when we did the 20 interviews, the telephone interviews with women, it came through much more strongly, when you were able to kind of tease these issues out in a bit more detail, that the unavailability or the delays around accessing community physiotherapy services and just the scale of demand for these services is an impediment to people accessing them, and I think that's echoed by our engagement with the physiotherapy departments in maternity hospitals as well, which kind of confirms that too.
Can I add to that just a line to say, yeah, we have worked closely, as you know, with the physiotherapists particularly in one site, and my understanding as the situation is now is that there's no women's health physiotherapists in the community. They're in the maternity hospitals. And what you get in one hospital may very well be different and is different from what you get in another. And there's also, I think, that the issue of women need to know that these services are available. And if you don't know it's not normal and don't know it can't be treated and don't know what service is available, I'll get it.
Okay, we're going to draw a halt to it there. Thank you all
That's
very
everything.
much for the questions. And anybody else with any queries, you can email it into our website and we'll find somebody to answer you. So I'm going to hand over now to Deirdre Daly to chair the next part of our morning session.
I think Petra's going to come online, but before she does, it gives me huge pleasure to welcome Petra Tenhupender, who's Technical Advisor for the Sexual and Reproductive Health and Rights at UNFPA office in Geneva. And she covers a myriad of topics there in the area of sexual and reproductive rights. Petra's a former midwife and she's former General Secretary of the International Confederation of Midwives, and I had the pleasure of hearing her speak on a few occasions. She's former Executive Officer at the Partnership of Maternal, Newborn and Child Health and Director of Dual Career and Staff Mobility Programme in the United States. Petra is the person who coordinated the Lancet series on midwifery way back in 2014, which is fantastic to have, and lead author on the international policy paper for this series. She's also co-authored the State of the World's Midwifery Reports 2011 and 14, and her expertise includes policy development, implementation analysis, operational supports to countries, and advocacy and building capacity. And a huge welcome to you, Petra.
Thank you. Thank you very much. Just checking that you can hear me properly.
Perfect.
So thank you to you for this wonderful invitation, and I'm delighted to have the opportunity to have listened in to some of the things you've been saying, unfortunately not from the beginning, but definitely some of these last pieces that you've been discussing. And today, you know, I feel really honored that I can do this keynote for you, because it's kind of an area of work that's also always been so close to my heart, and that I've not really ever seen as much on as I have heard in these last couple of minutes, and as I've seen in the papers that you have. So I'm wanting to talk a little bit about Survive, Thrive, Transform. And I know you mentioned it already earlier, Deirdre, Thrive. At a global level, and I'm going to take you from the global to the more granular around what realities are for all of us, care providers and care seekers. So if we look at the global arena, in 2010, it was agreed that, let me just see that this works now. Yes, we set up, oops, it's gone too far. So we set up a program called Survive, Thrive, Transform in the Global Strategy for Women, Children's and Adolescents Health. So on Survive and Thrive, these are really very high level, overarching, relatively, you know, not very finessed ways of looking at things like ending epidemics, reducing premature mortality from non-communicable diseases for the Survive piece. The Thrive part comes, as for you, also for me, a little bit closer to my heart, about ending or ensuring and strengthening access to sexual and reproductive healthcare services, strengthening early childhood development, reducing pollution to some extent as much as possible, but specifically achieving universal health coverage. Because if we don't have that for a lot of countries around the world, the capacity for women and their families to survive and thrive are quite limited. This screen is not doing what I want. Oh, there's not my slides. Sorry.
Petra, I'm just coming on for a moment to say, yeah, it's sometimes it's slow response. So if you press once and wait a few seconds, it might come on. Same happened to me too, and all of us, I think.
Sorry about that. Yeah, it was a little easier on the tryout last night. So the Survive and Thrive pieces are important and interesting, but really what always makes my heart tick faster is Transform, because survive and thrive are the basic premises, but we all know that if there is a good, if women have a positive and a strong experience in pregnancy and childbirth, their capacity to kind of make the things that they've learned and how they've experienced pregnancy and childbirth help them to transform what's around them. You know, there's this saying, you teach a man to fish, you teach a man to fish, you teach a woman to fish, you teach the community. So, you know, there is a kind of an impact, a wider impact that goes beyond survive and thrive when you pick up the transform angle. And again, I'm just giving you a list here of free and equitable and good quality education, crucial, and eliminating harmful practices and violence against women, and then making sure that the legal identity and birth registration are available to all. And those are things that in our minds and in our world are just given. You know, you know that this is how it works, and this is you know, what every woman is entitled to. But in principle, but in reality, for many places and many countries, as you will know, this is not news, that's not the case. So one of the ways that this is being dealt with at a global level is with country leadership, with strengthening a health system, making it resilient also to big shocks like a drought or war or things like that. Bringing together a large number of actors so that you can look at several angles of what people need and what communities need at the same time, whilst engaging and making sure that it is community leadership. And then looking at things like research and innovation, and some of this, the innovation that I think is crucially important is the work that you're doing, focusing very much on morbidities, because you know, there is an enormous wave of morbidity in many countries in the world that we don't even know of. You've started to look at what's happening in Ireland, and you know, I applaud you for that. But I think this is something that needs to be taken up much more widely. So then the last piece, and that in the area of UNFPA, United Nations Population Fund, is very important. That's very important, is attention for humanitarian and fragile settings. And there are more and more of those. And it's harder and harder to provide the kind of services that women need in that situation. Fortunately, UNFPA has a large number of midwives who are actually in camps and in humanitarian settings, making sure that the quality of care that is provided is at the best possible in the circumstances. And we're really very proud of what they're achieving. So who are important people to play in this game, if we can call it that, and who are you know, who need to take responsibility for the things that are happening? And of course, at the top of the list are governments. Of course, also UN organizations like ours, like mine, funders, people who are non-governmental, so that, for example, ICM has a strong voice, getting stronger and stronger thanks to all the midwives who've joined ICM. About how experience are for women, what quality of care really is, what midwifery is, and we're writing State of the World's Midwifery 2021 to again be very, very clear on it's a different profession from nursing. It's not the same. We really, you know, look at maintaining health as long as possible, making sure that we provide the services that women need in a way that also acknowledges and gives space to physiology and to maintaining physiology. International and national, regional and non-governmental organizations are very important because they do a lot of the legwork very, very close to where women are. And of course, women's groups kind of gives a lot of guidance and suggestion on what would work for us. When, you know, when women's groups among themselves or within their group can organize or own a certain area of work or of development for their community, it's 50,000 times stronger than anything that, you know, we kind of help them with from the global level. And then the development agencies, just mentioning Irish Aid here, that you know, are crucial for making some of the funding available. So coming from that perspective, I'm now landing into your conference, the Maternal Morbidity Conference, and you're talking about things like continuity of care, the emotional needs of women, anal sphincter injuries, stuff that we really don't even think about at the global level. And that's why I'm so delighted to be here and to be able to talk with you about this. You know, that orientation to the labour room unit is beautiful. It's exactly what we need, not only in the countries where I work a lot, but also for lots of other European countries. If I think about my midwifery practice, women never got an orientation to the labour ward. They would just kind of, you know, start with labouring at home, and then if there was something needed, they would all of a sudden have to go to a hospital where they don't know the way, particularly to the labour suite. They don't know, you know, who they're going to meet. They're not, you know, they don't understand what the expectations are. So some of these things are really, you know, they've helped me look again at the reality for people, rather than in all these big policy documents and strategies and drives for making things more effective or more pragmatic. The healthcare needs after the termination of pregnancy. We see a lot of unwanted pregnancy internationally in situations where girls and women really have no say over their own body or over what they're experiencing. So, you know, let alone thinking about what they might need after a termination, if they can even get one. And then the therapies, for example, for health anxiety in perinatal mothers, again, something that I've experienced a lot in my practice as a midwife, but that I don't see enough of in our international world. So, you know, the opportunity to really kind of delve into some of these topics that you're covering has been really very special for me. So then, you know, you're also talking about things about collaborative practice with other providers, absolutely important and so hard to make happen in countries that are on the development path. You know, position is power in many of those situations, and it's really hard to get some of the providers to understand that together is more than alone. That you know that you don't that really pushing for what women need and looking at what women need and tailoring the services to that gets better results than saying, oh, well, we just have to do a cesarean section, or we'll have to refer that woman to the next level. And it's really important to you know, for me to kind of see some of these things and to hear what you're talking about. For example, you know, the other thing I really loved, a national maternity strategy that I don't even think exists in the Netherlands, to be honest with you. So those are, you know, those are really wonderful pieces to have your thoughts on, to have heard a little bit of you talking about, and to really take with me into the work that I'm doing. So on the side of transform, because that's really what you know, what I think is the bit that's also not well enough defined and implemented. It's about women and girls and men and boys and communities and services and society as a whole and the world as a whole. But what do we really mean with that? So to me, in the experience, in the work that I've done in Rotterdam in my practice, I found that many women kind of came into their own after they'd had a child, and they kind of realized that there is a resilience, that there is a capacity in them that they didn't have or didn't know they had before. And when you know, when you see that happen in women, and I've seen quite a lot of that, it's just amazing. It's just the piece that you really wish every woman to be able to get to and to achieve, whether she has children or not. So in the work I'm doing, and when we look at this global strategy that I spoke about at the beginning, survive and thrive are easy. Not easy to do, but easy to measure, because you can say, how much have we done of this? How many people have survived? How many more lives are safe because we have emergency obstetric care in places, etc., etc. But the transform bit is harder. You know, if there is less clarity on what that means. Sorry, I've gone one too far. And people really don't. They don't know how to apply that in a way that can give more space for the outcomes of transform and the way women have worked on transform themselves, or what's happened in themselves, to inform policies and the practices that go with them when they work at country level. So there is a there is a great amount that still needs to happen there. And in the work that you've been doing and that I've been seeing here, I think there are a lot of lessons that can be learned, and that you could share more widely. And I would encourage you to share specifically the transform piece widely, so that we really can learn from that and can help other people and other countries apply it and recognize it in their societies and in the women and in the health services, and hopefully more, kind of give them the opportunity to think about putting out a good, strong midwifery services, facilitating it from beginning to end, so from education until full practice and postgraduates capacity involved in that. So I'm really heartened by what I'm seeing that's happening in your work. So when I look through the topics that are coming after my presentation here, there are a couple that are just amazing, and the one thing I just kind of wanted to raise with you is that there's only one on the midwife. So, out of the 24, the support needs of midwives in relation to perinatal mental health are only one out of the 24. And I think, I'm delighted that there is one. So I'm not criticizing at all. I'm just thinking, but, there is a lot of this that's also needed for us as midwives, or for you as midwives. And it's important to think about how that works. I know from some of my colleagues in the Netherlands that specifically with the COVID situation, it's really hard to kind of do midwifery as we do it, lots of home birth and lots of postnatal checkups at home, etc. And it's not because it's harder to do it physically, but because the anxieties from COVID, but also through COVID from other issues that they are dealing with, and finding their transform piece, actually, becoming a mother and dealing with the morbidities that you're talking about are really taking much more time. And that, women need that time and are entitled to that time. So the midwives that from my practice, for example, are really kind of doing much more work and needing more support themselves as well to be able to manage that. So on the side of what support could then look at, the things that we talked about, because I had a little chat with them a couple of days ago, is that they're working with other health professionals and coming together around this issue of how do we continue and maintain our capacity in this period. How do we, how can we be creative to kind of talk with amongst ourselves, but also have a little bit of fun so that we can offload that energy that's tough to deal with. Of course, some of them rely, kind of resort to food and alcohol and drugs and partying, although that doesn't last very long because there's just not a lot of energy for that. But a lot of it is also finding the right sounding board at home. I think most of my colleagues really spoke about that and said that's the piece that they need most, and that many of them do get. They found a way to discuss things at home, even though they don't go into details, and they don't make it very complicated for their partners or their families to understand. But just that bit that you can kind of talk about over dinner, or that you can talk about after dinner with your partner, really makes a big difference. So the last piece of what I wanted to talk about is Midwifery 2021, which is the report that we're doing there now. And in 2014, we created this State of the World's Midwifery, the Midwife Pathway, or the Woman's Pathway to Health. And this is really about, you know, the pillars at the bottom. You'll see the pillars 1 to 10. So what's needed in order for the woman to be able to just walk her pathway to health without realizing or needing to realize all these pieces that need to be in place so that she doesn't fall off the pathway or she doesn't fall into a crack in the road. And those were really very helpful, specifically for people to understand that it's not just a profession, it's a whole system that needs to stand together to support quality maternal newborn healthcare and specifically midwifery care. So in the 2021 report, we really wanted to write up something about the midwives themselves, us, you know, as how are we supported? What is our pathway? What is needed for the midwife to have a proper pathway into, into her profession, but also into the work that she does and the ways that she communicates and helps the development of the profession and the safety of the women in her country. So, you know, this is the list that we're working with: education, primary, secondary, and professional, regulation, the things that ICM works on as well: continuing education, a professional association, a functioning health system, and paths to grow into related areas, because not everybody is and can be a midwife for all of their life. You know, I'm one of those examples. After 15 years or 18 years, I think I was kind of done with that part. I needed to move on to something else. So you have opportunities to move into academia or government or international work or home care, for example, or you can completely focus, as some of you are doing, on maternal morbidities or postpartum mental health or breastfeeding or young mothers. So the piece that we're looking at is how do we, we would use the same image as we have here. So, but then what's the midwife pathway? And one of the things I really want to make sure that we pick up in that is the morbidities that you've so aptly and so beautifully described. And to me, the way that we make that work is by kind of collaborating together on what's needed for the midwives to be able to kind of have that continual that kind of surrounding network and the continued pillars under their pathway in order to continue to be able to do the kind of work you're doing and that the practicing midwives in Ireland and elsewhere are doing. So the midwife pathway can be all those technical things that I spoke about before, but I think there are also other areas that we could look at. And in some places, midwives are actually providing care along the life course. So it's not only for pregnancy and childbirth, but it really kind of goes beyond that into other areas of the life course. And in some of the countries that don't have a lot of midwives or where there's not a very strong health system, the midwife can, for example, become a kind of a GP in the community where she lives. There's a program in Afghanistan that's called Family Health Houses, in which the community builds a house, and the young midwife who is going to kind of be the midwife in that house goes to school in a neighboring city or somewhere a little further away. So she doesn't come home, she has to stay there and take her coursework. And then and the practical practice as well. And when she comes home, that house that's been built by the community and that's owned by the community becomes her practice, and the top floor becomes her home. So there's a real investment from both sides. The midwife invests in learning, the community invests in building, and together they improve the care and the health of the community. And oftentimes what you see happening, and that to me is, for example, a beautiful transform method or transform idea, is that the midwives become kind of a GP. They go beyond only midwifery, but also they become part of the establishment in a positive way of that community. So they're asked about women's issues in the community when the men sit together to decide, what are we going to do next, etc. I have to close off. No. So There are other things that also have attracted me to continue in this area of work over, since I've ended my actual practical piece. And attention to maintaining physiology is one of my pet topics. It's just one of the things that I think is so important. And the morbidities piece, again, that you're working on is such a key part of that. Respectful maternity care, we've all worked on. Defining the impact of midwives is one of the pieces that we want to cover in State of the World Midwifery 2021. So we have a paper that's going to be published in the Lancet Global Health on that, because the impact of midwives is not only physical, it's in very, very many areas. So we're expecting that to be launched in December. So I'll keep you posted on that. And also looking at what is the return on investment for midwifery. In the we did a small part on this from one program in Bangladesh in 2014, but we're working towards having a much more extended piece of research and again a Lancet Global Health paper on the return on investment for midwives, so that you can tell a government, so if this is what you have, and this is what you want. If you invest in midwives, this is what is going to be in addition, what's going to be, how much better or stronger or more sustainable it's going to be for your health system. And then, of course, all the things that are important that keep us going also include things like dance and poetry and art and song and the things that make us happy. So that to me is what I wanted to share with you today. I hope I can stay kind of hang in for a little bit of the next sessions and the next pieces that you're going to be working on. And again, as there are, if there are any things that you'd like to raise, or if there's something you would like to say, I'm more than happy to take questions or to explain further. And thank you again for inviting me. It's been a delight.
Thank you so much, Petra. I've been trying to get you over to Ireland for so long. You weren't able to make our last conference in 2018, unfortunately, so I'm delighted. And for the audience, I think I just want to go back on one thing. Petra and I have had a couple of conversations over the last week about this. And the whole idea that when we were developing the resources with women, we talked about survive and thrive, but the fact that we didn't talk about the transform. And I've been thinking about it so much since, and thinking about transformation at so many levels. But I want to give you, and I don't know if she's on the conference, but in the words of one woman who became part of our public participation initiative and research, she said that level of engagement with the research and with us and with the team had unleashed the social activist in her and transformed her. And all of the women on a personal level talked about pregnancy, birth, becoming a mother, transforming them personally, for the good or for the bad. And I'm really thinking now about, our workshop later on, and it's women's voices and all the voices together. It's that, what did you say? Together is more than alone. And to transform the services into something that would actually meet women's needs and help them to be positive in motherhood. So I'm going to invite questions. I think that there are, I don't know if there's any hands raised or comments.
I'm just taking
or any
a look.
Questions.
I'm just taking a look there, Deirdre.
Thanks
I don't
very
see
much,
any
Deirdre.
hands raised just yet. If anybody would like to, I'll certainly invite them in.
I think the other, while we're waiting for comments, maybe if I just make a comment about, you said it was, there was less clarity around measuring transform, and there certainly is less clarity about it, but women can talk about it powerfully on a personal level, And I think that, and some of the things that we've talked about over the years, engaging with the women in the way we have done, as I said, that none of this would be possible without them, but they have also shaped and transformed us as researchers and the way we think about things. So we've
Yeah,
benefited.
that's wonderful to hear. And
Yeah.
and you know, I think that the only way that we can do proper research is if we do that together with the women and the communities that we're working with.
Definitely.
Yeah, it's beautiful how you've kind of made that part of your work from the beginning, not like an afterthought. Oh yeah, these are the outcomes we need to check with a group of women as a sounding board. No, from the beginning, right, involved deeply into all the details.
Women's influence.
Yes, yes, yes. And the transform bit to me is so powerful because it transforms the world, but it also transforms the woman. You know, as that lady was saying, you know, having been involved has brought out an activist. Those to me are like, those are the crucial seeds of strengthening society and strengthening communities that we need.
I think I have, there's a lovely comment in here from midwife lecture in Ireland, who says, thanks to Petra for all the wonderful work she does for midwives, women and girls.
My pleasure.
The other Deirdre, are you moderating the hands?
Yes, I am moderating hands.
Thank you very much.
Yeah, I don't see any hands raised just yet. No, people are just taking it all in.
I think so. And I mean, I think the way you took it from the research to the focus on the midwife, yeah. In order for this to be a reality, the midwives need to also maybe transform the way, not just midwives, but all maternity care professionals need to transform the way we interact with women and we offer services and
but also look out for yourselves. I couldn't do the 2018 conference because I had a massive burnout, and it's really easy to get in our line of work, whether as a practicing midwife or in my field. So, you know, that kind of the way that we work together as teams and how we support each other is also crucially important and can only improve the quality of care that women get.
huge thank you. Huge thank you.
Thank you. Thank you.
Great presentation, thought-provoking. Thanks, Petra. Many thanks, Petra. So I'm just, it is 10:46, Petra. I think you've given us an awful lot to think about. Your slides are absolutely gorgeous. I'm going to digest them. And a huge thank you, a pleasure. And who knows, when the world changes again, we'll have to get you over in person.
I would
So
love
a huge thank you to you. And I'm now going to end this part of the conference. So thank you.
I'm going to hand over the chair now to Deirdre Daly, who's going to introduce our next speaker. Thanks, Deirdre.
Thanks, Cecily. I'll read out a couple of lines from your biography, Richard. It's getting too long at this stage. Professor Richard Green is director of the National Perinatal Epidemiology Centre in Cork, and he's professor of clinical obstetrics there in UCC since 2007. His research interests include maternal fetal medicine, epidemiology, health services research, including quality of service and information and use of information technology towards improvement of healthcare. Specifically, his future interest lies in the development of the National Perinatal Epidemiology Centre in Ireland as a national service with the aim to improve clinical services for women giving birth in Ireland. And recently, Richard became Chief Clinical Information Officer for the HSE, that's our Health Service Executive. So congratulations, Richard, and over to you now, and we'll take some questions and answers afterwards if we have time, and people as they're listening can post them in the Q&A section. Thanks, Richard.
Thanks, Deirdre, and thanks very much to the organisers for inviting me to speak. And while I'll be speaking about maybe different maternal morbidities, I think the lessons that I'll talk about have already been well expanded on this morning through a fantastic series of talks and research. I think the most important one, which we might come back to, is that actually the women themselves are sometimes the best advisors on what we should be looking at and how we should look at it. So the National Perinatal Epidemiology Centre does a number of different things, but we have a number of national audits that we run, including looking at perinatal mortality, interacting with the Vermont-Oxford network on very small babies, looking at planned home births, assisting the maternal death inquiry, and looking at therapeutic hypothermia. But the one I'm focusing on today is severe maternal morbidity. We are also involved in other areas around the maternity services. And I'm not going to fix on this, but broadly, we were put in place initially to try and translate outcome data for mothers and babies into improved clinical practice. And that's what we're all about on this day today as well. Generally, how we work with the units is that we have a dedicated audit manager working closely with the audit coordinators in each unit, building and maintaining those relationships, feeding back individual hospital reports on the various audits. We go through a process of identification of outliers, and we work through the National Office of Clinical Audit escalation policy around that. We run various workshops, feedback forums, seminars, and we have an annual study day around one or other of our audits. I suppose we've always built around the idea of closing the audit loop. So it's easy enough to develop the fact that you want to look at an audit, how you do it, do the statistical analysis on it and all the rest of it, but you have to come around the other side. And thankfully, in the last few years, we've been very fortunate in the upper segment there on the left-hand side, coming back to 12 o'clock. We've been able to interact with the National Women and Infants Hospital Programme, and that's now allowed us to get purchase around some of the recommendations and beginning to put some of the learning into practice. So in the severe maternal morbidity, this basically looks at about 17 reportable events. One of those reportable events is other, because there's lots of issues, so we have another category. But you can see on the left-hand panel there, they include various things, including major obstetric hemorrhage, septicemic shock, pulmonary embolus. So they're fairly significant morbidities that put the woman's life at risk, essentially, is I suppose where we're at. And about 400 women a year experience this based on 2018 information. About half of the causes, about half the patients are affected by major obstetric hemorrhage. It's the most common significant morbidity that we measure and look at. So I suppose to go back to a little bit of the theme of this morning is that we need to listen to women. And this is a statement from Claire Jones, who's the patient women's representative on our maternal morbidity group, and who's feeds back very strongly to us and gives us really, really good advice. But basically here saying that it's really important that we actually look at this information, that's how we can learn and improve services. And indeed, she has given us very directed help and assistance in moving the audit forward. So if we look at what are the kind of key findings, and we're just taking 2018 and comparing it back to the base year when we started was 2011, it's about just under 7 women per 1,000, or 1 in 150 maternities are affected by one of these 17 or so major morbidities. The variations there are variations in rates between the units, and I'll look at some of those. Major obstetric hemorrhage is the most reported and accounts for about half of the cases. Peripartum hysterectomy we mentioned because it's increasing, and this may be related, or appears to be related, to morbidly adherent placenta as the most reported indication for it. Interestingly, the perinatal mortality in Ireland runs at around 5 per 1,000 births, and in this group of patients it is closer to 40 per 1,000. So this is just looking at the case numbers, delivery numbers, and our deliveries have dropped over those years from around 67,000 to around 60,000 a year. In the early years, we were pretty certain that the increase in trend was probably related to ascertainment of cases and people learning the reporting mechanisms in the audit. But it's become very stable in recent years, and the numbers continue to increase. So we believe that the increase in the last few years is a real increase. As mentioned in the list of conditions, we've just highlighted that the kind of top three are major obstetric hemorrhage, accounting for about half, and then renal and liver dysfunction, which are come from multiple different causes. Pulmonary embolism, I'm just going to highlight, it's one that we believe is completely underreported because many of the cases are probably not dealt with by the maternity hospitals, and we have had a specific audit around that, which has proven very difficult to get good information. We also look at a number of management criteria, including ICU, CCU admissions, and interventional radiology, and I'll come back to the ICU, CCU admissions in a minute because it does cause slight problems with the data set. Just in a trend, the blue line is the trend for all of the severe maternal morbidities. MOH is the orange line, and the ICU, CCU admissions you can see there, is also trending upwards. Now, about half of those admissions had no other maternal morbidity as defined in this audit, and it's mainly due to a number of the smaller units where they have patients requiring above standard care in terms of observation, and very often the safest place for them to put them, or the only place they have staffing to do that, is in their ICU. So therefore we do get, we pick up a lot of patients there who actually don't have really significant morbidities, however, they have needed additional care. So if we look at we undertake an assessment of the cases in individual units by using funnel plots. And for anybody who hasn't seen these plots before, basically you would expect a much wider confidence interval for a smaller unit and a much tighter confidence interval for bigger units. And so we have quite a lot of small units, one or two in the middle, and then we have a number of kind of 4 big units in the country. And so therefore this is an attempt to try and assess the rates in an individual unit. And here we can see that the small units that are outliers are based really around the ICU admissions, and not because they have more cases of truly severe maternal morbidity. And we'll show you that corrected in hopefully in the next slide. Actually, it's obviously a slide jump. This was for the MOH rate, the massive obstetric hemorrhage. So we are just when we did this initially, we had a number of units that were above the 97th centile here. But part of the reason they were was that in the definition, women receiving blood products were actually included. But many of the women who received blood products actually didn't have a massive obstetric hemorrhage. And this is something we've noticed in the last few years, where there's been a move clinically to use fibrinogen as a kind of a prophylactic in women that are bleeding, although the evidence isn't good for that. And it's actually begin to affect these numbers. So we're having to adjust this definition going forward. So if you remember a moment ago, I mentioned about the ICU cases, putting 1 or 2 of the units up here. When we adjust for the cases that had no major morbidity as per the audit, it brings pretty well all the units back into the expected limits, with 1 outlying unit, and that unit was affected. So the other thing we look at in the audit is that we actually look at the level of maternal care based on the critical care definitions. And you can see from this that we have a small number of women who end up with level 3, the old ICU care, if you like, and that was based on advanced, requiring advanced respiratory support or whatever. quite a large number ending up in level 2, and then a significant number in level 1, which would include all those cases that we discussed just a few moments ago, needing higher levels of care than the background normal ward care. So I suppose when you look at the women then and look at some of the characteristics of the women that end up with these conditions, are there any lessons to be learned? And probably the main one is that we find these major morbidities occur more often in older women in comparison to the background rates in the whole population. BMI is about 2/3 or more of the cases are associated with a high BMI or an obese level of BMI. And when you compare that to the general population, from data from the general population of women would put about 45% of women are in those two categories. What about the mode of delivery? And this is the question that was asked earlier this morning. There are various reasons for this, but about 2/3 of them have had delivery by cesarean section, about 1/3 by vaginal delivery, including operative vaginal delivery. Now, some of that is because there's reasons why the cesarean section took place, and some of it in massive obstetric hemorrhage definitely seems to be higher in women who've had cesarean section, and we have some detailed work on that from a couple of years back. So out of this, we generally build recommendations, and I suppose some of these get repeated for very good reason, but one of the things is that we believe the robust clinical audit needs protected time of clinical staff, and in many of our units people are doing the provision to these audits above and beyond. So we continue to raise this and hopefully it'll be something that will get additional funding in time. We've also been recommending a quantitative approach involving volume and weight assessment to estimate blood loss. And we're picking up blood loss particularly here because massive obstetric hemorrhage is such an important issue in this audit. And the development of a national toolkit to assist the standardization of this approach. And this is being addressed now with the National Women and Infants Health Programme, as mentioned by Peter McKenna in the previous talk. Also, the implementation of a case assessment audit of major obstetric hemorrhage, so looking in detail at each of the cases. And we did this back in 2011 to 2013. We restarted that audit in 2020, but because of COVID, we put it on hold because it's a pretty intense audit for those who have to complete it. We're hoping we might start it again in 2021. But it has provided really valuable lessons previously. So I mentioned the value of being linked to the National Women and Infants. Sorry, my slide just didn't seem to have gone forward there. And we have recommendations that have been progressed, including a specific pro forma for documenting major obstetric hemorrhage and rolling that out. The other thing is that we have been also looking at the 10-group classification system for cesarean section, but actually we're more interested in it as a defined classification system for pregnancy, which allows us to really look at individual groups. And we have 16 of our hospitals have reported on this recently, and that's now gone up in 2020 to all of the units reporting on this. And this allows us to look in to try and delve down into groups to see where the major or where the morbidities are occurring. So one of the things that from a couple of years ago, and I thought it'd be valuable for this audience, was that we actually decided to have a look at the patient experience or the woman's experience in a piece of work done by one of the INPEC epidemiologists, Sarah Meany. And we did intensive interviews with women in a qualitative methodology. And some of the lessons will be very similar to what you've heard this morning, but just to go through those. So that's just to outline. I'm just going to go on to the next slide. But basically the kind of areas that we identified a real problem where you have women with morbidity, significant morbidities, is that they end up, the kind of messages coming through is there's a feeling of powerlessness. The morbidity treatment itself is a problem. The morbidity management after they get home is a problem. And in the longer term, the maternal behavioral responses are a real issue. And this, the reason I'm just presenting this is just because it did feed into some of the recommendations, which I'll come to in a few minutes. Women find the events debilitating. That's, I don't think, any surprise, but they have high levels of frustration and anxiety. There's the fear of the unknown, and there's actually coping with the impairment. That, you know, these morbidities impact greatly on women's quality of life, and I think Girdle presented some of that really, really well this morning. I hated not having control. You're tied up to the machines, strapped in, you can't move. There's nothing you can do to make yourself better. How about the morbidity treatments? Women are accepting of the uncontrollable nature of the adverse outcome while being treated for the trauma, and they were satisfied to relinquish their autonomy at that point in time for the safety of themselves and their baby. But they expressed difficulty adjusting to the long-term treatment. And women were concerned that, you know, around the communication issues and very often around medications. And this was particularly that they felt that sometimes they weren't given adequate pain relief. So there's some real lessons to be learned there. And I'll just give you a moment just to read this, but this was about consent, and it's incredibly informative. The idea of asking somebody who's ill and in a morbid condition to be consenting to something. And the woman says, I tell anybody in this situation, don't ask the mother to sign it, because if you asked her to put my hand on the Bible in the morning, I'll still say I didn't sign it, even though her partner felt that she did. So there's a lesson for us in terms of dealing with people in these very, very difficult scenarios. So how about the morbidity management? And this is adjusting to the impairment. Very often women felt that there was very little information provided to them on the practicalities of adjusting to the impairment that they might have going home. Their capacity to discontinue daily tasks, dependence on family members, and this played into women who had morbidities that kept them in hospital during the pregnancy and in the situation when they went home. They felt the GP had a key role, but they conveyed high levels of trust in their GPs and the advice that they got from their GPs. They were dissatisfied with the transition of care, however. It was felt that during treatment, the responsiveness in care of the staff was excellent. However, once they transferred to the wards or they were on the mend, we seemed to lose that intense relationship and involvement with them. And this was just a story of a woman who was in the HDU, got transferred back to the ward. There was a kind of a lack of understanding that she'd been quite ill, and therefore she was just seen as somebody who had a cesarean section and therefore should have been able to respond to her baby when in fact she wasn't in a position to do so. So that there's real lessons for us in terms of identifying these individuals who have had not the normal outcome that we would have expected. Sorry, now my slides are taking a bit of time to respond. Maternal responses, women expressed concern around the impact of their morbidity. Particular reference was made to their partners and the trauma that they perceived their partners had around that time. The safety of the baby was considered the priority. and I suppose the really important lesson to me of all of this was that there was a delayed reaction to the trauma. Women stated that it was not until their family had settled into a new routine that they began to reflect back on the complications they experienced themselves. And sometimes their depression and upset and anxiety and everything only started then. And that could be 3 to 6 months down the road. And just two final comments here. At the time, I wasn't really sure what had gone on or whatever, because I had a blood transfusion as well on day 3. But afterwards, when I got home and you think, I don't think that's normal as it should be. I don't think everybody goes through it. You're not sure, you haven't done it before, as it's your first baby. So you start researching it yourself. And that's a message and a theme that came out earlier today as well. This is a little bit about the partner's worst nightmare, all coming through, and the feeling that, you know, irrespective of the time, that it felt like a lifetime for them, waiting to know what happened to their partner and their baby. So I suppose putting this work together with some of the lessons that we've learned along the way is there's a real need for communication between the clinician and patient before discharge, debriefing on the event, and information on the management in the home setting, ensuring the support to both mothers and fathers from a counselling point of view, and then actually looking to provide the care when the woman wants it further down the road, whether that be 3 months, 6 months or 12 months. And one of the things that we've put into our last report, based on pulling this information in as well, is that we really feel that there's a need in during the antenatal education phase. We need a public education program on maternity morbidity and modifiable risk factors. We hear lots about age, BMI and all the rest of it, but I think it needs to be also pointed out that there are real risk factors for morbidity. And our current antenatal education should provide information to women so they have an understanding that morbidity can occur and achieve a complication awareness, if you like. If there's a real high risk for significant morbidity, they need a specific education program. And we've suggested that the national standards on antenatal education should provide guidance on specific education for maternity morbidity awareness. So I'd like to thank you very much for listening to me. Happy to answer any questions. And I would just point out to you that our Impact Virtual Study Day is in January, and it's going to be around choice. So the choice options for birth. Thank you very much.
Excellent. Thanks a million, Richard, and a gorgeous sort of flow through from morning to services to this. I see there's a couple of Q&As and the numbers are increasing as I'm talking to you. So I have a couple myself, but maybe I'll start with, is there someone managing the Q&A box, or will I go into it myself?
Okay, so Kirsia has a question for Richard. Are there any moves to regularly audit experiences following difficult experiences with a reasonable time period have passed? And also a comment about the link between perinatal mental health services for people who have had a very shocking or physically shocking experience, including the partner, as a way of debriefing so that people are caught rather than falling through the net.
Yeah, thanks, Kirsty. I think one of the things that has improved significantly in the last year or so is that now we have a perinatal mental health service. So at least we, while they may not have the capacity to do all of these, they can actually help us in terms of understanding some of the ways we need to deal with these people. I think we have to recognize that women who have significant morbidities, and perhaps maybe not even significant, some lesser morbidities, actually do need a follow-up. And postnatal care is something that maternity services have kind of moved away from. And I think maybe we need to move back to focused care in these cases. So from the point of view, is there anything formal? I mean, it's fine to talk about expectation studies. What we probably need to do here are patient patient reporting kind of studies. And I know there is a piece of work currently being planned for a PhD study to actually look at how you do this for for women, because I think proms are probably a better way to get directed information from these patients, and the work of MAMI has actually showed us that some of the lessons, and the women who are involved have pointed to the lessons. So I do think we need to, as a service, learn from that.
Thanks. If I can just add to that and link it to one of the points you made, Richard, it's that delayed reaction. And I think that even in the National Maternity Experience Surveys, I know that one of the statistics that's given is that women were satisfied or happy stroke very happy, 80+% of them were happy stroke very happy with the service. But that's a service that's antenatal, intranatal, 2 to 5 days. And what you've got here, even for women who go through labour and birth with a glorious experience, that have every needs, not just met, but exceeded, they're telling us 3 to 6 months down the line before they're even thinking of their own health. Never mind that you put a trauma on top of that. So there's something, there's a common message, and it's not coming out from MAMI or you, it's coming out from the late 60s and 70s in the UK, postpartum care, that whole part, the whole purpose of being pregnant, to enable and empower women to become the best mother they can be. We've somehow lost it, or not lost it, but it needs more than we're doing at the moment to meet the needs of women. And I think that that's sent there, that delayed reaction. It's even a delayed reaction to returning to themselves as women, you know. Anyway, that was just a comment that I wanted to make. I think, Dee, there might be some more questions there. I don't know if there's any coming up for Richard.
I don't. So Paula has made a comment here, Paula Miller, about peritraumatic dislocation induces delayed onset. So that's just kind of feeding into the comment that you made there, Deirdre. And I suppose, Richard, it's just a question in relation to the reference that you referred to, the study about women's experiences of severe morbidity. If we can just make that available, maybe on our website afterwards. Thank you very much. I don't see any hands raised if anybody wanted to ask a question that way. No, I don't see any.
We have another couple of minutes, but I thought maybe just to wind this session up until I hand back over for Cecily. Richard, you made a really lovely point there about starting audits, but never closing the circle. Maybe we could finish on that positive note there about closing the circle, and what you mean and how do you think we can really achieve that to improve women's health?
So I think one of the frustrations that I had as kind of with the impact reports up to a couple of years ago was that we would make recommendations, but we didn't have any management group that would actually take them and say, no, we're not doing that one. And that's fine. It's not that you have to take everything. Yeah, that one's valuable, and there's lessons about it, you know, like, and with respect to massive obstetric hemorrhage, I mean, PBH is on the increase. So forget about the really massive ones. Big bleeds are on the increase. Small bleeds are on the increase. And this is an international thing. There are other countries now, like Wales, actually have only one major quality improvement program for their maternity service, and that is to deal with PBH for the next year or two. So I think it's a case of what we need to do. If we learn lessons, we need to, even if we can't institute them all, we need to take some of them and move them forward. And as I said, thankfully, in the last couple of years, because we've had a focus on maternity services, albeit that Peter showed that it now has gone into gynecology and everything else as well, it's still around women's health. And at least we can begin to move some of those recommendations forward, whether they're coming from research like the MAMI study or they're coming from our audits or whatever. But it's pointless studying these things and getting information very often from women who are pointing us in the right direction, and we're not doing something about it. So we do need to always look back and make sure that we are actually using those lessons and moving forward.
perfect ending. Thank you so much. I'm going to switch off my video, switch off my mic and hand back to Cecily. Thanks.
Thank you, Deirdre. And thanks to Richard as well. And I would like to thank all the speakers that gave of their time and expertise today, particularly Petra ten van Hooper from the Netherlands, and our national experts, our concurrent speakers, and all the people who came and presented their posters as well. Every one of you that took part today contributed your time and your expertise and your energy, and you all did it for the reason that we do the MAMI study, which is to try and improve maternity care. And I think all the studies that you presented were coming up with the same kind of things that the MAMI study has said, which in the women's words is that there are some women who suffer having had a baby, sometimes mild consequences and sometimes very traumatic, detailed consequences that have an effect on their lives. And all the way through the MAMI study, the women have been saying to us, okay, we're telling you what our problems are. What are you going to do about it? And it's time something happened. And I'm glad to say that, you know, we think it's time something happened too. So this afternoon, we're having a workshop where all the plenary speakers from today are meeting with us and some more national experts as well. And we're going to try and hammer out some policy and practice changes that will actually make a difference to women's health in this country, we hope. And from that, we're going to develop an action plan so that something actually happens. You know, we feel it's time, you know, the changes should occur. And I hope that you feel the same way too. You can go back and make changes in your own area or your own country. And if you take back one message from this conference, I hope it'll be that every time you see a cute baby or a happy family, that you remember there is a mother behind that happiness and cuteness. And that mother may be suffering quietly without telling anybody and without having the support and help that she needs. So please, let's remember her. And in our daily work, try and do whatever we can to improve care for women. Thank you all for attending the conference today. Your questions and your contributions have been much appreciated. I hope to see you all again in a couple of years' time with our Minding Mothers with Morbidities third conference, which hopefully would be face-to-face by then. Thank you all for attending and for contributing. Best of luck. Goodbye.